Hello, I'm David Healy. I'm a professor of psychiatry, and I'm giving this talk on why are antidepressants difficult to stop for Bob Whittaker and MAD in America. Way back when I was young and confused, I took a sidestep into a research lab. I thought it was going to help me work out who I was, who we are, what being normal and what being mad means. And girls also confuse me. In the lab, I encountered the SSRI group of drugs, and between them and the things I've heard from people listening into this talk and reporting to risk.org about the effects of SSRIs have helped me distinguish between being mad and being normal. And as regards girls, I'm still confused about them, but I figure they might hold the key to some of the problems we have with this group of drugs. The talk you're going to hear is going to be based completely on things that you've told me. You're not going to hear anything expert, as it were, or views of mine. Fortunately, the lab that I went into was looking at serotonin reuptake. And this was just before the SSRI group of drugs came out. This is the first of the SSRIs here, Zelmed. Prozac was only the fifth. And because I had a background as a doctor and working on serotonin reuptake at a lab, companies who were bringing these drugs on the market thought I'd be a good person to educate other doctors about what the drugs do. And because I was working closely with the pharmaceutical companies and had worked in a lab, the people who in the psychopharmacology field had discovered the new drugs and how they worked and things like that were happy to be interviewed by me, which is a way to get a feel for what had really happened. And among the people that I interviewed was Arvid Carlsson, whom you see here, who won a Nobel Prize. He was the person who created the idea of a selective serotonin reuptake inhibitor and made the very first of them. Interviewing Carlsson, it became clear, as he said, look, it wasn't about brilliant men. It was about having a new gadget through which you could look and see things no one else had ever seen before, and just reporting on things that nobody else had ever seen before, people thought you were brilliant. But there was one really brilliant thing about him, which was he listened to the people who were on the drugs, and based on what people like you and other people were actually saying to him, that's where he came up with the idea of an SSRI. People had said to him, among the older drugs, which we all thought were pretty much the same, there were ones that were more likely to make you serene, less anxious. And this led Carlsson to figure, let's make a drug that's a pure serotonin reuptake inhibitor. And all of that led to this article that you see here, which came out 33 years ago, was written a bit actually before that, saying, look, the SSRI group of drugs aren't particularly good antidepressants. They're more serenics. They're anxiolytics. Problem is, we've got a benzodiazepine crisis, and no doctors out there are going to believe that tranquilizers or anxiolytics that don't cause dependence could really exist. On the other hand, they will believe that antidepressants don't cause you to get hooked to them. And this is why the SSRIs became antidepressants rather than anxiolytics. Not particularly good antidepressants. And because I was closely linked into the pharmaceutical companies at this time, I ended up being the chair for the UK launch of Zoloft. And here's an article which gives you the talk that I gave at that meeting, which says, look, serotonin is more primitive than estrogen. And if we've got drugs that work on serotonin, we're going to see things that we've never seen before, both good and bad. And we need to keep an eye out for these things. This is a talk to a company who had just found Viagra because things that they didn't expect to happen had happened in the clinical trials. So it seemed an obvious idea to say, look, let's keep a lookout for these things that might start happening. This was not a message Pfizer were actually keen to deliver. They wanted everybody to think that they knew all about Zoloft, and the only job for a doctor was to prescribe it, and the only job for a patient was to take it. And this all caught in this Michael Loenig cartoon about a depression being a simple chemical imbalance in the brain. At that stage, there was no evidence for this. Carlson didn't believe it. That was not the reason that he made these drugs, to fix the serotonin system. He thought the serotonin system was absolutely normal, and that's why these drugs could be helpful. But the key thing here is, the doctor's going to give the pills, which is what Pfizer hoped you do. What was also happening here was we were converting over cases of Valium to cases of Prozac and Zoloft. And as you see, these pills, as Loenig brings out, do restore normality to the situation, the normality the doctor wants for himself. If a drug like LSD or SSRIs is working on a normal serotonin system, as you can see, this is an image for LSD, you can expect good things to happen and bad things to happen. And with the SSRIs and LSD, that's what happens. There are good things that can happen and bad things that can happen. When people later told Carlson that your SSRIs can cause people to become suicidal and to commit suicide, he said, yeah, I know. And companies knew all this very well, because before they brought the drugs on the market to treat people, they'd run healthy volunteer trials. And in these healthy volunteer trials, they'd seen a range of problems. People became dizzy and anxious and depressed, and they had sexual problems, severe sexual problems in just short exposures to these drugs. And they became suicidal, particularly on withdrawal. It became clear that these drugs could leave problems after them once you stop them. And this is Tracy Johnson, who was a 19-year-old girl who was on duloxetine and withdrew from it and committed suicide. And she's not the only healthy volunteer who ended up actually committing suicide or becoming very aggressive. So the companies knew all these problems were likely to show up years before they marketed them, and that gave the companies a chance to prepare their defenses. Now, before we go into all that, I need to introduce you to this, which is 400 years ago, we got a problem. And the problem is here. It was created by a man called René Descartes, who said, look, our souls reside in the pineal gland up in our brain. And the proof of this is, for instance, if you put your foot too close to a hot flame, an image of the flame runs up the nerve, you see there, to the pineal gland where the soul is looking at it and says, oh, well, we should remove the foot from that. And you remove your foot. For Descartes, from his point of view, there was reflection there. There was thinking, and we ended up with a wise movement. Now, this laid the basis for the idea of a ghost in the machine, that our soul is a spiritual something which is in the body, which is a machine and is just a brute machine. It also laid the basis for Descartes to say, cogito ergo sum. I think, therefore I am. It's the thinking that proves that I, as a soul, as an individual, exist. It took 200 years for us to realize that that was wrong, and that when reflex actions happen, there's no reflection. There's just the opposite. They're automatic and unconscious. There is a wisdom, but it's not the wisdom of the soul or the brain. It's the wisdom of the body that makes sure that we withdraw our foot from the flame. And this opened the door to sentio ergo sum. I feel, therefore I am. That my body is maybe the real me. And the people who picked up this idea were William James and Carl Lange, who said, actually, when you think about our emotions, what these are is the body trying to tell us things. The brain looks at what it's hearing from the body or feeling from the body and often gets the wrong idea about what's going on. that it can be awfully tricky to interpret the signals coming from the body. But this is what our emotions are. Now, 10 years later, Freud changed all that and said, you may not be able to read what the body is saying, but I, the expert, can interpret what the body says. And this proves to be a problem. What Freud in actual fact is saying, rather than you thinking and therefore you are, or you feeling and therefore you are, I'm thinking and what I think is what you are. Now, Freud's dead. He's been replaced by biological psychiatry, or so we think. But in actual fact, Freud talked about libido and things like that down in the body, which is something no one can measure. It was an unreal concept. It could mean one thing on Monday and a different thing on Tuesday. No one ever worked out what he meant by the word. It's a word that we use, we know roughly what we mean, but that's not what Freud meant by it. And it's the same thing with serotonin now. It's like Freud's libido. It's no more real than the tooth fairy. If you ask doctors to measure it for you, they can't. But on the basis of this serotonin, like Freud and his libido, they figure they know more about what's going on in you and who you are than you know yourself. So Freud isn't dead. Freud is dead. Long live Freud. Biological psychiatry is tremendously Freudian from this point of view, and we need to get away from that because that's a serious problem for us. When the psychotropic drugs first hit the market, back in the 1950s, before the antidepressants, the thinking behind them was based on James Lang thinking, which was, let's fool the brain. And at the benzodiazepines, which you see here, as compared to the older sedatives, which just knock the brain out and put you to sleep, these drugs were able to help you when you're anxious and under stress and leave you awake so you could do things. And how did they do that? Well, they relaxed your muscles. And the brain looks at this and is fooled into thinking, this guy's giving it an important talk and his muscles aren't all that tense, so he can't be anxious. There was a further group of drugs that's used to treat people who are anxious, and these were the beta blockers. And these drugs slow your heart rate, reduce your perspiration rate, remove a shake from your hand or quaver from your voice. And again, the brain looks at this and says, hey, this guy's not anxious. But cardiologists also use these drugs to slow your heart rate and to reduce blood pressure. They know, however, when you stop the drug, there's going to be a rebound. Your heart rate's going to increase a lot. And your brain may think that you're anxious when you're not. It's just the drug being stopped and it's rebound happening. And they warn you, don't think you're anxious because you're not. This is just an effect that's going to wear off after 48 to 72 hours. The beta blockers taught me one more important lesson, which is way back in a pharmacology practical. I don't want to tell you how many years ago. I had to give a beta blocker to a colleague. And, the books all said the best known thing in all of medicine is beta blockers slow heart rates. So we had to give her a pill and check her heart rate and see what happened to it. And about 15 minutes later, she became anxious and we checked her heart rate and it had speeded up. It had not slowed down. So I'm Irish and trained in Ireland, and the code for Ireland is IRL, or in real life. And what this taught me was that in real life, what's real is what's happening right in front of you. What's in books is not real. It may be helpful, but it's not real life. You need to go with what's happening right in front of you. Now, let me take you to this. This is a scene which you won't see happening right in front of you these days. This is T-Rex over on the left. And if you look at his eyes, above his eyes, there's almost no brain at all. He's got a bird brain, a reptile brain. On the right-hand side there, you see the human cortex, and that's the bit that's all in pink. The reptile brain is essentially just the upper end of the spinal cord, which you see, which is more whitish there. And it's got two dots in it. It's got a blue dot and it's got a greenish dot. The greenish dot is usually pink, so blue and pink. The blue dot's where the norepinephrine is, and the greenish dot there is where the serotonin is. And there's almost none in our brains. Less than 5% of the serotonin in you and me is in our brains. It's in our bodies. Now, for the moment, I'm going to suggest essentially that 100% of the serotonin in you and me is in our bodies and none is in our brains, because I'm treating that upper bit of the spinal cord as part of our body. It's certainly not part of the human cortex. It's not where Descartes thought the soul was, or not the way Freud would have viewed the brain. Now, many, many years ago, in the last millennium, I hate to say, this is the unit that I was working in Wales, and we thought we'd try and experiment to see if Arthur Carlson was right, and that SSRIs produce a serenic effect that people on them can pick out from drugs that are antidepressant but don't work in the serotonin system. So we took a bunch of doctors and nurses who are totally healthy on no pills of any sort, and we got them taking SSRI or a non-SSRI. And it turns out that actually they were able to tell the difference between the two different drugs. 1 in 10 of the people taking the SSRI, in fact, actually became suicidal on it. But apart from that, mostly they became serene. But the intriguing thing that came out of this was none of the patients in the unit had any idea that any of the staff were on any meds like this. And within 48 hours, the patients were coming to me and saying, "Is that doctor on a pill?" And I'd say, "Yes, he is." "And is he on an SSRI?" And I'd say, "Yes, he is. How did you know?" And they could tell by the facial expressions, the body language, the way the person was behaving, that SSRIs fool the brain the way benzos do and beta blockers do by reducing sensory input, by making you less reactive to things. They're acting on the body to reduce the sensations the body picks up and transmits up to the brain. So the brain ends up thinking that you're less anxious, except when you become suicidal. But this points to the fact that no doctors or nurses in that unit could ever tell by the look of a patient what drug they were on. The patients, however, looking closely at us the whole time, could tell these things. So the question is, who are the clinical experts here and who weren't? And that's a point to bear in mind. Now, this shouldn't have come as a surprise, because even before we ran the experiment, here's a Peanuts cartoon where Lucy knows Charlie Brown is serene. He's less bothered about things that would normally bother him. And she knows exactly the reason why. He's on Prozac and she hates Prozac. She can't have any more fun with him now because of this. And here's a further experiment which says the same thing. This is from over 10 years ago, where a group of researchers took a bunch of healthy volunteers and brain scanned them, and that's the image you see on the left. And then they gave them 1 dose of an SSRI and brain scanned them again. And that's what you see on the right. And the researchers said, "Hey, look, 1 dose of an SSRI can turn the brain off. 1 dose of an SSRI is not turning the brain off. 1 dose of an SSRI is turning the body off so that the sensory impulses up to the brain aren't happening to the same extent, and the brain looks much less active." That's what's going on here. There's a serenic effect that happens within hours of your first pill. It's not the case that these drugs take weeks or months to work. They don't. You can tell within a few hours whether they're doing what Carlson would have wanted them to do and whether that suits you or not. But no one's told us. Now, that's what happens when you go on the drug. Just like stopping the benzos and the beta blockers, we're going to stop the SSRIs and see what happens. But before we do that, let me show you this image here, which is from an article 20 years ago. And the dots in blue there are showing you that when these drugs come out first, almost no one has had them before. They're on them for the first time. But pretty quickly, within about 3 or 4 years, the red dots show you that actually more than half of the people on these drugs have been on them for a long time. They're not just on them for a few weeks. And by the time these drugs are out for 10 years, 90% of the people taking the drugs are on them chronically. Now, they weren't supposed to be used chronically when they came out first. The idea was 3 to 6 months. So 90% on them chronically is happening because people can't get off them. there's more and more people on these drugs every year, not because we're putting more and more people on them, but because there's an increasing number of people stuck on them and unable to get off, scared to get off. Things feel so bad, they say, if you try and take me off these drugs, I'll be dead. Now, the company, well, actually, I should tell you before this, within about 3 or 4 years of the drugs being on the market, GlaxoSmithKline had more reports of dependence on paroxetine to the British regulator than the British regulator for drugs had on all benzodiazepines combined during the previous 20 years. So this was a huge problem, much bigger than the benzodiazepine problem. The companies had ways to solve it. And one of them was to let them, well, they were able to say, look, we ran our randomized controlled trials, which are the gold standard. And they've shown that there's only mild to moderate problems when you halt these drugs. You can come off them cold turkey and there's no big deal. That isn't totally unreasonable if you let the companies do one thing, which is to say, anybody who feels anxious and depressed when they stop the drug, well, that's a relapse of the illness or a new illness. It's not withdrawal. That's wrong. They knew from the healthy volunteer studies that was a lie. The other thing is that in the early days, before these drugs were on the market, no one had been exposed to them before. So there was no one there expecting that things could be awfully bad and that they might become suicidal. They did, in fact, become suicidal. But, it's a different population to the trials you see recently, which are called randomized controlled trials like Antler, which says, yeah, lots of people are able to get off these drugs without a huge problem. The thing is, you can't run a randomized controlled trial these days because you can't. Most of the people in a doctor's practice who get approached about, will you enter this trial, if any of them have missed a dose of a pill just for one day and become suicidal, the last thing they're going to do is to say, yes, I'm happy to enter this trial. You're only going to get healthy SSRI users, people who've got no great reason to think they might have any problems coming off the drug. They're the ones that are going to volunteer for these trials. So you're not getting a randomized trial. Okay, so let me move on from that to this, which is the other part of the program, which was companies knew they were going to have to get away from words like dependence and withdrawal and addiction, and they trotted out as psychiatrists to say, oh, these drugs are not addictive, and the word withdrawal and things like that is completely wrong. You should use the word discontinuation syndrome. That also became a bad word pretty quickly, and all sorts of other words like symptoms on stopping, SOS, were introduced to try and describe the kinds of things that can happen. What are the kinds of things that can happen? Well, you might be surprised to see me flag up your skin. The point behind this slide is that most SSRIs began life as antihistamines, and many antihistamines over the counter are serotonin reuptake inhibitors. And if I talked about problems getting off antihistamines and talked about your skin and your gut, where we used antihistamine drugs to treat ulcers, you wouldn't have been all that surprised. And in the clinical trials going on and coming off the drugs, there are gut problems. Nausea and cramps are among the major problems when you go on the drugs first. Dizziness is also, and when you come off the drugs and things like that, and allergic responses. And the skin and the lining of your gut, which are all continuous, this is the boundary between you and the world. It's not your brain. Okay, so we've got some risk posts on just the skin problems that can happen and the gut problems, and they're pretty grim. You don't hear about them too much, but they're pretty grim. One little old joke perhaps brings the point out, which is when a man's skin surface area increases ever so slightly, and the blood flow goes to the skin to support the increase, and the serotonin, which is in the blood, which, the serotonin in you and me is in the blood going to our skin and guts, and in the nerve fibers going to our skin and guts. So the serotonin's going to this extra little bit of skin, and, the old joke is that, and there's no blood left to go to his brain, which brings the point home. This is an image of something that looks much more like a brain problem, which is what got called brain zaps or electric head or things like this. Now, one of the interesting things about this, if you try and find out what's involved here, you can go on loads of websites which will say to you, this was happening right at the start when these drugs came out. And it was. There were all sorts of people, doctors and others who were on these drugs who talked about, the awful electric zaps that they had. But you'll also find that nobody's researched this or reported on their research because, as the websites openly tell you these days, we don't want to deter people from taking their antidepressants by thinking there could be a withdrawal problem from them. Now, in actual fact, when you dig a bit deeper into this, you find that it's nothing to do with your brain. It's to do with the skin and scalp of your head, maybe. In particular, the main trigger to this is turning your eyes to the left or the right. So it's not a brain effect, it's a body effect. Now, let me take you back 150 years to Germany, where 3 different doctors had 3 different patients who reported to them, look, when I go to a crowded marketplace, I end up having an I'm going to die experience. And this has been so shocking, I can't go back to crowded marketplaces. I'm so scared of the whole thing. And one of the doctors said, look, this is a visual processing problem. The others said it's a nerve problem, but they didn't mean a Freudian problem. They meant literally your physical nerves. There's something gone wrong here. And this condition, particularly the bit about not going back to the marketplace, gave the condition its name, agoraphobia. 100 years later, Donald Klein invented the concept of a panic attack and said, look, we've been handling agoraphobia with behavior therapy, trying to say, you can improve things by not avoiding things. Just expose yourself to the problem and this will improve things. The real way to cure things, Klein said, was to find out what's causing the panic attack, the original I'm going to die experience, and stop just trying to treat people for avoidance. He thought it was a suffocation reflex. He was wrong. And we still use CBT now to treat, people who are having panic attacks. The latest incarnation of this is PPPD. Now, PPPD is something we in Risk heard about because we had a lady who we were treating for protracted withdrawal syndrome. She thought that's what she had. We thought that's what she had. She then, about a year or 2 ago, said to us, look, I've just found this thing called PPPD, and I think it's a better fit. And I think it probably is in her case. What's PPPD? PPPD is persistent postural perceptual dizziness. The word dizzy, unfortunately, is just too mild a word. People don't think it's a serious problem. If we swapped dizziness for vertigo, you probably get a better idea. If you're up on a tightrope like this guy here, and you got a vertigo attack, you'd have an I'm going to die experience, and the last thing you'd ever do again would be to try and go up on a tightrope. And that's the problem our lady has, and a lot of other people have. It's like panic attacks. When you're talking about balance, our eyes have a huge part to play in this. The vestibules of our inner ear have a huge part to play in it. Our body, the sensory receptors in our bones and joints and muscles and skin that tell us where the bits of our body are, have a huge part to play in it. They all have a lot of serotonin input. Mess with that, and you risk causing a balance problem, which lots of people, when they take an SSRI first, have. When we asked the people who created the PPPD concept, could going on a serotonin reuptake inhibitor cause PPPD? They say no. We in Risk have reports of people getting PPPD after starting. When you ask the PPPD creators, could SSRIs cause it on stopping the drug? They say, yes, it could. This is because the vertigo is even more severe when you try to stop the drug than it was when you go on the drug, and it can come back from time to time. So we've got lots of reports of this in people halting the drug, and that's what happened to our lady. There is a avoidance behavior therapy approach, which is called vestibular rehabilitation therapy, which involves exposing you to the stimuli that have caused you a problem and letting you adjust them. It's a thing you can call an interoceptive behavior therapy. That's helpful, but that's not what happens to you. These days, you get referred for trauma therapy for the problems you had in your childhood that are causing this problem. And you also get put on SSRIs, even when your problem has started after going on an SSRI or after halting it. You're told SSRIs cure this problem. You need to remain on these drugs for the rest of your life. Now, eyes are involved in PPPD. They're also involved in visual snow syndrome. And Nicky McQueen's juggling act painting here brings out marvelously some of the key issues in the talk that I'm giving you. Which is we've got to juggle our bodies to make them work. And you see she has an eye there. Visual snow syndrome came into existence about 10 years ago, but in risk, we had reports of visual snow syndrome before people created the word. And these problems on antidepressants go back to the 1960s. They were blamed on the anticholinergic effect of drugs back then. They're not caused by that. They're caused by the serotonergic effect. And here's some of the features of it. Let me show you what they look like. Here's a normal image on the left and the same image with visual snow all over it on the right. The image on the upper left is after images. This is palinopsia, which SSRIs can cause. I should tell you that going on an SSRI can cause PPPD and coming off can cause PPPD, and tapering plays no part in this. It's the speed of tapering makes absolutely no difference. And as I say, it can happen on the drug before you even begin to taper. It's the same with visual snow. This can happen after you go on the drug. It can happen when you're coming off the drug. It can happen after you stop the drug. The rate of tapering makes no difference. But you get images like this, the after image problem. Down on the lower right, you get night blindness. And if you've got a job which involves driving a car at night or even being able to socialize at night and you've got visual snow problems, you have a serious problem. On the upper right, you've got floaters. Now, all of us have floaters. And when you go to an ophthalmologist, if we've got one or two floaters, they can usually spot them and say, I can see your floaters. But when you go along with a ton of floaters like this, ophthalmologists can't see them. And they start saying to you, this is all in your brain. It's not in your eyes. There's nothing there in your eyes. They also can't understand why, when you don't have a social life and can't work anymore and become suicidal with these weird eye problems and think you're mad when ophthalmologists say there's nothing wrong with your eyes. This makes it easy for them to say you've got a functional neurological disorder. The lower left image, let me show you this. This is something you can download from the risk site where this talk will be. You can hopefully just about see the little wisps of white beneath the clouds there. Again, these are things that ophthalmologists can't see in your eyes and give them the impression that you've got a mental problem, functional neurological disorder, FND. FND is the modern version of hysteria. It's the kiss of death for anyone who wants to be taken seriously. It's a problem that's increasing with the SSRIs and drugs like that, or any drug toxicity. It's linked to specialism in medicine, or what we can call partialism, where people know more and more about less and less. And if you've got issues in the rest of your body that have nothing to do with the toenail or whatever that they've got a specialism in, they figure, well, it must be mental. This isn't the case. So visual snow is caused by SSRI drug toxicity, and it's a serious problem. It's probably happening a lot more often than people think. And it's like post-SSRI sexual dysfunction. One of these two people is on or was on an SSRI. Whether on or previously on, it has made their genitals numb, it has muted their orgasms, it's killed their libido. They weren't informed of this risk when they went on the drug to begin with, because we don't want to deter people from taking their drugs. And their partner, whose life is just as much affected, wasn't informed either. And we're not having a national conversation about the fact if it's him that his sperm count goes through the floor, or if it's her that she's much less likely to have a successful pregnancy. These are things that as a country we should be talking about and should, we should be informed about so that we can make a reasonable decision about how to handle these issues. So this is post-SSRI sexual dysfunction. Well, it happens on when you go on the drug. It's not post, but the problem begins even before you halt. It's not linked to tapering or the speed of tapering. Slow tapering won't get rid of this. This is a further problem that is going to be there potentially for the rest of your life. So when we talk about protracted withdrawal, this is potentially something there for the rest of your life. At the moment, we have no treatments for it. We've known about the problems since the 1960s with the older antidepressants. We were using the problem to treat premature ejaculation problems by the 1970s. Just 1/10 of an antidepressant dose an hour before intercourse could leave a man who had premature ejaculation problems better able to function. We've known since the 1980s that some people stopping SSRIs could have enduring sexual dysfunction, and this could be a grim picture. We known in the 1980s that companies ran healthy volunteer trials which showed over 50% of people were having not just problems, but severe problems on these drugs. And that's only on them for 2 weeks. And they lasted after the drug was halted. But doctors like me helping run clinical trials for pharmaceutical companies were told, don't ask about sex, which left the companies able to claim their clinical trials, the gold standard, had shown less than 5% of people have a problem when they halt these drugs, or have a problem as regards sex. And of course, you can halt them quite easily, and then the sexual issues, any ones that may have been there, will be gone. The companies knew that both of those ideas were wrong. As you've seen, everything you're hearing has been reported to me and to Risk by people like you. And here's 3 people like you. There's Roy and Bryn and Simon. And this is a PSSD network podcast about PSSD. And this is this is worth much more than most of the books about medicine and these drugs these days. It goes to the heart what's increasingly the biggest problem in all of medicine, not just mental medicine. And here's Bryn saying, and this is the key point, getting PSSD undermines your faith in the medical establishment and the whole system of science as we have it. The fact that no doctors listen to you when you come in and say something that's terribly clear to you, they just don't listen to you, they laugh at you. And Roy's saying this links into the idea that, you lose your emotions on these drugs. What you're losing is your feelings, your sensory input, which leaves you feeling like you've got no emotions. And Bryn says a further key point here, which is, nobody's going to believe us, guys. When they hear what we have to say, they're going to say, FDA wouldn't let a drug that does something like this on the market. Well, FDA have a public health mission, as you all know, and you might expect that they wouldn't let it on the market, but their public health brief is to ensure the health of American pharmaceutical companies. Just like my friend who I gave a beta blocker to, her heart rate speeded up when it should have slowed down, so we can get just the opposite to PSSD, which is persistent genital arousal disorder. Rather than your genitals going numb, lack of sensory input, you can have that, but you can also have genital akathisia, or irritability, which causes persistent, unwelcome orgasms, so unwelcome and distressing that women have resorted to a clitoridectomy to try and solve the problem. Okay, now, this just a first note. I should have vaguely mentioned to you, when PPPD came up, one of the people reporting to Risk introduced us to the concept of visual vertigo. This sounds very like the agoraphobia that kicked off the PPPD story. It's also clear that visual vertigo and some elements of visual snow can respond to a drug called acetazolamide. I'll tell you more about that later. But there are also hints that drugs like acetazolamide can help PGAD. This is also going to come up a little bit more in a lecture I'm due to give in 4 weeks' time on antidepressants and homicide. Now, for this slide, I wanted to show you a picture of Bruce Springsteen on a paddleboard, which is his happy place. He loves being on a paddleboard, and there are thousands of pictures out there. They're all copyrighted. So you're just going to have to believe me. The book says he was out in his happy place one day on the paddleboard, and he just bursts into tears. So he calls his doc and says, "Hey, doc, I've just burst into tears." And the doc says, "Oh, that's no problem. Just take a sliver of an antidepressant, 1/10 of a dose, and it'll be fine." And it was. Now, we've known about this before the SSRIs came to the market from the older serotonin reuptake inhibiting antidepressants. So it's not just SSRIs. It's been around a long time, but no one hears about it. But I want to contrast Bruce's experience there with his other experience reported in the book, where it's a 2 or 3 page account of akathisia, which is one of the best accounts you can read, actually. And I've just picked out some little bits of it here. It's really well worth reading, although he doesn't call it akathisia. It's unquestionably akathisia. Let me just focus on the bottom 3 lines there, where he says, "There was no life here, just an endless, irritating, existential angst embedded in my bones." And I think bones are where it is, not brains. And it was demanding answers that I did not have. This is a hint that he could have committed suicide, or he can understand people actually committing suicide. So he calls his doctor quickly, who does not say, "Take a little sliver of an antidepressant, add to the dose or whatever, because that'll make the problem worse and will put you into an escalating situation where you get more and more of the SSRI, which is causing the problem." So you've got 2 different kinds of problem here, and the response of the 2 different problems to reinstituting the antidepressant is just the opposite. Bruce's doctor tells him, "Take clonazepam," and it works a treat. Wouldn't have worked for the crying, but works a treat for this. Bruce hinted that people become suicidal on these drugs, and when the companies ran trials of their antidepressants to bring these drugs on the market, as you'll see, they had to whip people off their prior drugs, and this turns out to be the most dangerous phase of the trial. Taking people off serotonin reuptake inhibitors or whatever they were on beforehand makes people suicidal at a higher rate than any other phase of this trial. The company response was to say, well, people have become suicidal on nothing. That's the same as being on placebo, so we can dump the suicidal events into the placebo column. This looks like and sounds like fraud, and FDA, because of their public health mandate to ensure the health of the pharmaceutical industry, paid no heed to it. But Study 329, which is run on paroxetine in adolescents, shows you exactly the same thing. The big black column on the right shows you the rate at which children who'd been on paroxetine and tapered, now they were given a 4-week taper, the rate at which they went on to actually become suicidal compared to the placebo column, which is the the stripy lines there over to the right of it again. This was the most dangerous phase of the trial. So when people who are on SSRIs write into the newspapers and all to complain about articles saying these drugs are dangerous, and they say things like, these drugs saved my life, they're absolutely right. They've saved the person's life from the problem the drug is causing. Here's another reported risk who told us and converted us to the idea that SSRIs can cause you to become alcoholic. Anne-Marie, this is over 10 years ago, and she's got a few posts and an article on this, and her experience and research has now been built into the Canadian guidelines for alcohol use disorders, which say, you've got to look for the fact that an alcohol use disorder may have been caused by an SSRI a person was on, and when treating an alcohol use disorder, you probably shouldn't use an SSRI. And it's not just SSRIs and alcohol. Other drugs that we're using have been driving people to use other drugs like amphetamines and all to try and manage the problem. So why am I reporting this to you? It's because alcohol and clonazepam are very, very similar. Alcohol is a tremendous treatment for akathisia. The best treatment is to get off the drug. But if you're on the drug and have akathisia, alcohol is a great treatment. And it's very similar to clonazepam. This is probably not the only reason why people drink on SSRIs, but it's probably an important reason. Now, this is perhaps the most important slide. And of crucial importance here is look at the 20 milligram dotted line there. And what this shows you is that Prozac and all SSRIs were brought on the market in the first place in toxic doses. You really shouldn't have been on more than 10 milligrams, and Lilly had trials showing 5 milligrams was just as good as 20 milligrams, and we'd probably have had much less problems if you're on 5 milligrams from the start. But 20 milligrams sounds low, so doctors bumped it up to 40 and 60 and 80. This is a disaster. You've totally occupied all of the binding sites for serotonin around 10 or 15 milligrams. Now, the other point to note is this slide has played a great part in persuading people to try and come off their drugs, which is a great idea. Because lots of people can come off these drugs. And if you can, these drugs which are going to shorten your life, you probably should come off them. Okay, so many people can come off without tapering, though. You can do it cold turkey. Others can just come off tapering prudently, and tapering generally is a very good idea. But the idea that, as you hear these days about hyperbolic tapering, that we know the science behind what's going wrong, and we now can get you off the drug without too much problem. This is as useful a myth in ways. It's a great myth to help you get off the drugs, just like the myth of low serotonin was to begin with, as a myth to help put people on drugs. They're both mythic. This graph that you see here doesn't take into account that, for instance, there are antidotes to the problems Bruce Springsteen had, and different antidotes for different bits of the problem. It doesn't explain why the beta blockers and the anticholinergic drugs, which you can produce graphs that just look just like this for them also, and there are problems when you stop them that last for 48 to 72 hours. SSRI problems can last for 48 to 72 weeks or 48 to 72 months. It doesn't explain why some people can quit cold turkey and others simply can't stop at all, no matter how prudently you taper. So the other aspect to all this is, though, what you've got is behind all this, the key important thing is not the science in terms of a graph that looks like this. It's the lived experience of some tremendous people, from Bob Fitterman way back to Mark Horowitz and David Taylor now, to Peter Groot's work on tapering strips, which I think is tremendous and really is the prudent way to go forward. People like Angie Peacock and James Moore and others. I'm sure I'm leaving lots of people out. When I use the word lived experience, that's too tame a word for the ability to remain sane and still able to help others in the midst of terrible problems that trying to hold these drugs can cause. So these guys are my heroes. But just to bring the point out, the graph you saw there on the left was a pharmaceutical company graph, which is kind of like a lot of graphs produced by companies, has got a little bit of a lie to it. It's where you manipulate the X and the Y axis so the problem looks the way you want it to look. If you even out the X and the Y axis, as I've done here on at the right, you see that coming off these drugs isn't such a big problem in terms of teeny bits of a dose change make a big difference. It's the fact was the dose, a 20 milligram dose to begin with was just a ridiculously crazy dose. It's like having a car that can only drive at 100 miles an hour in a city that's got a 20 mile an hour speed limit. It's only going to cause problems. Now, I keep saying it's the body, not the brain, but of course the brain plays a part in it. And The part that the brain plays is that the cortex of the human brain is the thing that pharmaceutical companies can program to get your doctor and me thinking the way they want us to think. Now, this operation looks awfully painful, but I can assure you, don't worry too much about the doctor who's been operated on. They feel just great afterwards. And these days, they talk more and more about precision psychiatry, which is laughable. I shouldn't think about that too much, or I will start laughing. But it's all about, magic bullet thinking, which is, we're going to get the drug that goes right to the heart of the problem, wipes it out, and you get out without any damage left behind. This is wrong, and this is not the idea that Arvid Carlsson had when he made SSRIs. He said they're not magic bullets. They're therapeutic principles. What's a therapeutic principle? Well, this image here shows you that there's 4 different kinds of constipation and 4 different kinds of laxative principles. And getting the right principle for you, for the constipation you have, is the way to help you. Putting you on the wrong laxative for you is something that will lead to treatment-resistant constipation. But when a company gets a license to claim their compounds are laxative, they want everybody who's got constipation to be on it. They don't mind if you're on the other kinds as well, but they want you to be on theirs, which is a definite recipe for treatment-resistant constipation. The same is true for the anti-diabetic agents, antihypertensive agents, and almost all drug groups across medicine, and the antidepressants. When Arvid Carlsson made a serenic therapeutic principle, he knew it was going to be helpful for some people, but not all. If it's not helpful for you, it's a pathway to a treatment-resistant depression, or what gets called protracted withdrawal, or a drug dysregulation syndrome that we don't know how to treat. And it's leading an increasing number of people to do what Anik Lemons, whom you see here, whose story featured in Mad in America earlier on this year, she had problems that have been going on for years. She decided to opt for euthanasia, and she's now dead. An increasing number of people are doing exactly that. Now, in her case, when you explore a little bit about the difficulties she was having a sensory problem, a hearing problem, but she was told her brain is broken and we can't fix the brain. This is all wrong. It's almost certainly the case that there are things that we can do, or will in due course be able to do, or simply knowing her brain was just fine and it was a sensory problem may have made a huge difference. Talking about therapeutic principles, I had a patient some time ago who had OCD, obsessive compulsive disorder, and he had a job which involved complex wiring systems. Well, if you've got OCD, bad OCD, this is a nightmare, trying to work out if you put the right wires back in the right place. So he put him on an SSRI, didn't help. Increased the dose, added other things in. Nothing I did helped. But a few weeks or months later, he comes back to me, and he's clearly much, much better. And he says, I stopped all of your meds. My meds? Huh. Well, I was pleased. He said, and I took up smoking. Before I did that, however, I did some research, and did you know there's a lot of data out there showing that nicotine can be helpful for OCD. I didn't know that, and I'm sure you didn't. But he handed me a bunch of articles, and the top article, curiously enough, had the name of a person that I knew on the authorship line. It was Arvid Carlsson, the man who had made SSRIs, which are the usual therapeutic principle that we turn to first for OCD. But he had recognized from people with OCD saying to him that your SSRIs didn't help this, but when I go smoking, it's much, much better. And he ran a study and said, yep, they're right. Nicotine is a therapeutic principle for the people who've got OCD that SSRIs don't suit. Now, one of the key points I'm trying to make here is, FDA say they license drugs on a risk-benefit basis. This is total baloney. FDA have no idea about establishing a benefit-risk ratio. Only you can. And you can see it from my man. He was the only person who could tell what benefit he was getting from nicotine, what benefit he was getting from SSRIs, and which was worth more to him. He also knows it's not a great idea to be smoking for the rest of his life, but he won't have known, but I could have easily told him and shown him a bunch of articles showing you it's not a good idea to be on SSRIs for the rest of your life. In fact, just SSRIs alone are going to shorten your life, but particularly when we start adding other drugs into them, you're much more likely to have a shortened life than nicotine will give you. So, okay, how are we going to manage the SSRIs you're on or have been on and are still left with problems? First thing you need to recognize is everybody from Biden to Trump to the Pope to EMA, FDA, to APA, AMA, the Royal College of Psychiatrists are all in the business of not deterring you from taking the sacraments, the good drugs that can do no harm. They'll scream and shout at you if you take bad drugs. They won't recognize the good things that some of the bad drugs can do. You got to recognize we've got a partialism problem. If you go along to a specialist and, you've got a problem on an SSRI, they're going to tell you you've got a mental problem when you don't. You've got a bodily problem. We've got to recognize that the medical literature is lying out of control. This is something I'm due to talk about antidepressants and homicide in 4 weeks' time, and I'm going to bring that point up much more. It's just totally out of control, and you can't believe it. One of the problems we've got is we've got a notional model of opioid dependence, which applies to the drugs that people abuse. And that gets applied to antidepressants, and it doesn't work. And the problem is we don't have a model for what's going on when we get dysregulated on antidepressants. Is there any model that might explain this to us? And I'm going to propose one to you. But before I do, I'm just going to quickly return to the brain bias thing and say that's a serious problem. Fluoroquinolones are a bunch of antibiotics. Now, they cause terrible bodily problems. They can cause your tendons to snap. They are disastrous drugs. If I had to go into hospital and was asked, are you allergic to anything? I'd say I'm allergic to fluoroquinolones, even though I've never had one. The last thing on earth I want to take is a fluoroquinolone. When things go wrong and people have terrible problems on these drugs, they get anxious, they get depressed. It's their brain being fooled. They get confused, they get paranoid. And hearing these things, the person who gave them an antibiotic says, oh, they're mental problems. Let's get a psychiatrist along who dumps SSRIs into the picture to treat the anxiety and depression, which is a disaster. It just makes things worse. It was the same thing with COVID. People had long COVID and all sorts of physical problems, and shrinks were called along to treat your mental problems, and they made things worse by putting you on SSRIs. It was the same with any of the harms the vaccines may have caused, or any vaccines may have caused, or any drug causes. If there's drug toxicity involved, the last person on this earth you want to see coming your way is a psychiatrist. And that applies to SSRI toxicity also. Now, in terms of a model that might explain what's going on, there's a group of people who have an I'm going to die experience, but they manage it without being told that they've got FND or all sorts of other things. And this is people having a hot flash during the menopause. Why do they manage it? Well, partly they manage it because they've got a context. They know it's coming. They know these things can last for a few months or a few years. They know they can be devastating briefly, but you get over them quite quickly, and you adjust. You change your clothing a lot more and a few things like that. Here's a lady who looks like a very competent professional person, perhaps a lawyer, but not just any lawyer. She's going to be a senior lawyer running a company, maybe even an attorney general, and looking terribly competent there at the moment. And you'd say, well, she could even be a leader of the free world. And that's because this is an advert for a drug, and she's on a drug that's causing the problem that's treating the problem that might get in the way of her leading the free world, which is she's got hot flashes. And SSRIs are quite good for this. She's on Brisdell, paroxetine. Well, in my experience, and I could be wrong, but it's just in my experience of a number of professional women leaders, who've been who are put on these drugs for hot flashes, who have no mental problems whatsoever before they begin. These are the people who find it hardest to get off the drug. And my hunch is that you're mixing two dysregulations together. You're mixing the dysregulation from the menopause and from the drug together. And this makes both of them harder to get over. 20 years ago, Prozac and most of the other SSRIs went off patent. And the company's rebranded, Prozac is rebranded here in this advert as Sarafem for a rebranded illness. PMT has been rebranded as PMDD, a terrible, devastating illness which causes women to commit suicide, etc. Now, in actual fact, the irritability word up there is interesting. It suggests akathisia, which is what is leading to the aggression. If you look at the data from the clinical trials, in fact, you find that the rates of aggressive episodes in women on SSRIs in these clinical trials goes up hugely compared with the women on nothing. The drugs may be useful. They may introduce some numbing, which may be useful, but they're not going to reduce the irritability, the suicidality, and things like that you get. There is another drug, though, where women don't do well on an SSRI that they can take that does make a big difference, and this is acetazolamide, which is also potentially helpful for PGAD, for visual vertigo and other things. I'm going to explain something about why it may be helping now in a moment. Before I do, this image here is great. It gives you symptoms of the menopause, and it's worthwhile downloading and looking at all of them. I just picked out a few here. You know, as a menopause and SSRIs give you on withdrawal, give you brain zaps. They give you brain fog. They make you vertiginous. They cause fatigue, which you may say is a depression. They give you osteoporosis. Well, you know the menopause gives you osteoporosis. SSRIs give you osteoporosis? Yes, they do. When you look at the website, which asks the question, why does the menopause have so many symptoms? The answer is because estrogen affects every tissue in the body. Well, it's the same with serotonin. It affects every tissue in the body. This is why you're having a drug dysregulation syndrome. What would a menopause model offer us? Well, it would offer us the fact that some women seem to be able to sail through the menopause without a problem, just like SSRIs. Other women can have a debilitating problem, just like SSRIs. It gives us the idea that, you know, your genes may predispose to you. If your mother has had bad problems, you may have too. It gives us the model that two women going through the menopause can have very different problems. They don't all have identical symptoms. It gives us the model that some women with problem X may take drug Y and it helps them. Other women with problem X take drug Y and it doesn't help at all. It gives us the fact that this can go on for months or up to 5 years. It also gives us the fact that doctors are not going to tell a woman, this is all in your mind, you're making it up, dear. Brain fog. I introduced brain fog, and this is the one thing with people with SSRIs in particular say, my brain is broken. And it's not. There's no cognitive function tests that we've done on women going through the menopause or people on SSRIs who show there's anything wrong with their brain at all. There is a problem, which is that, you know, automatic behaviors, if they're dysregulated and not functioning right, and you try and solve them by thinking, by reflecting on them and concentrating on you know, the piano keys, or your golf swing, or your gym floor routine, you know, you're going to make things worse. When the brain gets involved, it makes all of these things worse. The answer to the problem is just brute repetition. That's how you put these automatic behaviors in place in the first instance. If the parameters of the behavior change a bit, you've just got to get back and repeat things endlessly till they become automatic again. As is the case for juggling. If you don't like the menopause model, think of yourself as being reborn. It takes 2 or 3 years to master our bodies and get them to a point where somewhere around 2 years or a bit more, maybe, you know, kids with a bit of music on, you know, they bop. They don't get taught how to do it. They master the body. They learn to move with the rhythm. This is what we can build ballet on, dance on, opera, acting, all sorts of things on. But if the basic mastery that the person needs isn't there to begin with, you cannot build any of these things on that. These things that need brain input, if only to read the musical score. So, in terms of helping you, we can mess with your mind. One of the things you've got to be told about is, we turned your feelings off when you went on these drugs. That's what they were all about, suppressing your feelings. As you come off the drugs, your feelings are going to come back, and they may be terribly intense. You may get off the drug, in fact, and it can take some months or years after you think the withdrawal is over before the color comes back into life. When we put you on these drugs, we change your personality. If you're a patient on a ward, you can see it in the doctor. If you're family and friends of the person who's on the drug, they can see the change in personality. And they may not want you to change back when you come off the drugs. And you yourself may prefer the numbed personality that you had on the drugs. So these are all things that need to be taken into account. Like behavior therapy and cognitive behavior therapy, and the vestibular rehabilitation therapy, a focus on interoceptive behavior therapies can work. And this fits in with a symposium webinar that Bob ran a few weeks ago on neuroplasticity. I think this is important, but it applies to the peripheral nervous system mainly. The other thing, I've got cancer infections here. You don't have to be medically trained to understand this. In fact, if you are medically trained, it really doesn't help. But we've known for 200 years that you could have a serious mental illness, and this is not caused by drugs, this real mental illness, and it clears up if you get a bad infection. I had a friend the other day who got in touch, and he's had protracted withdrawal problems after Prozac, damage after Prozac for 30 years. He stopped it 30 years ago or more, and he's had ongoing problems till recently. He said, look, hey, it's all cleared up. I'm back to normal. He developed cancer, and it's been treated. Cancer and infections and treatments, heavy-duty kind of infections, can change the immune system, and this is possibly what's going on. Again, this is not part of the brain. It's the immune system. But I don't want to get you racing out there to get infected and get cancers. Chances are, if you're going through the problems trying to get off these drugs and are very dysregulated and doing pretty well, if you get a cancer or other illness or an infection, it's going to make things worse. My point is, you've got to give yourself some leeway. You've got to be gentle on yourself. You don't want a therapist who tries to explain they know what's going on here. You've got to have room for the possibility you may be doing awfully well, then you get a setback and you don't quite know why. You don't want somebody working with you who's going to gaslight you. You do not want to hear about trauma during childhood, as far as I'm concerned. If there's any trauma, there is serious trauma, which is you've been gaslit by the doctors who put you on the drugs, who laugh at you when you've got the problems. If you've got a therapist now who is any good, they will be willing to go and stand with you in front of the prescriber and say they think the drug has caused the problem. If you don't have a therapist willing to do that, I'm not sure you want that therapist. We can mess with your mind or we can poison your body. Now, treasure this moment. You have a doctor saying to you, have you considered nicotine and alcohol? Nicotine is not a problem or is not a treatment for dysregulation, but there's a great chance the SSRI didn't suit you in the first place. And maybe a small contribution could come from taking something that might have been a better treatment for the OCD or anxiety generally that you had that led to you being put on the SSRI. Alcohol is a great treatment for akathisia, not the only thing to use. After nicotine and alcohol, the most vilified group of drugs in medicine are the anticholinergic drugs. They're great drugs. They're marvelous. I'd take one any day before I take an SSRI. The lady in the picture here who's got the burning feet has a peripheral neuropathy. Her nerve endings have been badly damaged. The only drugs we know that cause peripheral nerves to regrow are anticholinergics like the ones you see here. There's compounds like DMSO and P5P, which there's blog posts about these on Risk. They're worth going to read. They may play a part for you. SSRIs come from antihistamines. There are less potent serotonin reuptake inhibitors. So rather than taper only, it's worth thinking about a switch to either one of the older tricyclic antidepressants or an antihistamine that are less potent serotonin reuptake inhibitors. Part of the problem with these drugs, and part of the problem with the hyperbolic graph, is it's not just removing yourself from the drug. It's the drugs bind so tightly to the receptor that they damage these receptors, and they need a chance to recover. Unlike the anticholinergics and a lot of other drugs, which are much gentler on receptors and don't break them irreparably. And acetazolamide, which is good for visual vertigo, which is good for some elements of visual snow, which may help PGAD, which there's, I think, at least 2 or 3 more things that can help. It's great treatment for, it's a good anticonvulsant as well. Not for all people. It seems to have antipsychotic properties, but again, not for all people. It's particular things, and it's not the heavy duty effects that you might want it to have. But here's a trick. It's good for glaucoma. When eyeball pressure goes up, and you can go blind from this, and SSRIs cause your eyeball pressure to go up. They increase the fluid production going into the eyeball, which puts the pressure up, which can cause you to go blind. Acetazolamide is a first-line treatment because it turns off this action. It reduces the fluid pressure in the eyeball and can save your vision. Acetazolamide is also used for altitude sickness, probably by the same mechanism. It reduces the fluid pressure, and it may be useful for akathisia, Bruce's bones, which don't have much room for fluid in it. Maybe if it reduced the fluid going into the skin of his bones, this is why he isn't akathisic. Not for all people. I'm not saying it's a magic bullet, but acetazolamide is great for altitude sickness. And did you know that SSRIs don't work at altitude? Or it may just be that they make you feel so much worse when you're at altitude and on them. Your altitude sickness is worse. That, because they're increasing the fluid production in all sorts of places in your body. So I don't want you to take any of the points made on the last slide as these are magic bullets. They're not. Don't race out and put yourself on them. The key thing is this. The only science being done in this area is being done by you, the people who are on the pills. You're the experimental apparatus and the experimenter in a privileged position along with your family and friends to say what's going on and to know what drugs and what doses you may be able to alter and tweak. You do not want to be involved with a person who thinks they know everything about all this and knows how to treat you, because they don't. There will never be any RCTs. There will never be any guidelines that will help an expert say, I'm the expert, what do you know? You are the scientist here. If they're going to do science with you, they need to support you. And that may mean, if you say, look, I think cold turkey is going to suit me, they need to support you doing that. It may mean if you say, I don't want to come off these drugs at all. I think I've lived through the kinds of things that can happen. I prefer the kind of person I am on the drugs. They need to support you in this too. It's not a case of them telling you how to live your life. That's your job. And doing science means coming to a consensus about the best way, in this case, to help you live the life that you want to live. So here's a science manifesto. And it takes the Loenig cartoon, and it starts here saying, antidepressants cause a complex chemical imbalance in the body. They do, a dysregulation in the body that we don't understand. This is what normal looks like. She's absolutely right when she says to the doctor, I'm pretty sure that that without your pills, I'm going to be just feeling just fine in a few weeks' time. In 9 cases out of 10, given the conditions SSRIs are given for, she is absolutely right. He's wrong if he says anything different. If things are normal, some doctors will be grateful to hear you say all this. Their job is going to be much more fun if they've got 100 free research assistants like you working with them and learning from you than if they're trying to treat 100 heart sink patients where they follow the guidelines, and every time they keep the guidelines, you get worse. That is not normal. There's a word for doing that, which is, that's madness. Now, I've been telling American doctors this for 20 years, that if the drugs work so well as you think and are as free of problems as you think, you are out of a job. You're going to be replaced by nurse prescribers, physicians associates, and others. That, you might say, well, that'd be great. It's not. There are hazards linked to it, which is the flood of people rushing in to be the prescribers are going to listen to you even less, look at you even less. They're not going to be working with you. They're going to be told by the managers to get you to conform. Everything needs to be the way we, the management, want it looking. Now, the thing here is, you have got to stand your ground. It's not as though you're totally alone. 15% of the populations of most Western countries are in the position you're in with these drugs. And even the ones who don't want to stop, you've got to bring them on the side, which is, you don't want to vilify the drugs. You want to say the problem's not the drugs, the problem's the system. Way back, 400 or 500 years ago, before Descartes, I think, Galileo got a new gadget. And he probably wasn't a brilliant man, but he looked at the gadget and saw things that no one else had seen before, saw through the telescope that the Earth couldn't be the center of the universe. Arvid Carlson, in the same way, got a new gadget which showed him where drugs go. I said where drugs go, not what drugs do. What he learned from all this was that he had an even better gadget, which was you, the person taking the drug. And Carlson's work in creating SSRIs and creating the idea that our brains and other parts of our bodies need much more chemical neurotransmission than we thought, should have demolished the Cartesian ghost and should have demolished the Freudian psychopharm expert that we've got. But that's not what happened. Because exactly when he was making these drugs, revolutions broke out across Europe, and the Democratic Convention in Chicago in 1968, and part of the problem was the revolutionaries figured, we don't want to lose the ghost in the machine. We want to hang on to it. That's our soul. That's what gives us individuality. It's not. The ghost in the machine, the cortex of the brain, is what churches and states and pharmaceutical companies and regulators and others use to program you, to get you to conform. Your individuality, and you're going to find this a bit tricky, your individuality comes from your biology. Listening to your body. All of our genes are different. There's none of us who have the identical pair of genes. We are individual, and it comes from our biology. Where does science come from? Well, it comes from listening to our bodies in this case, and having our family and friends and others on these drugs listening to their bodies too, and working with maybe the occasional person, from outside who is prepared to listen and work with you to come to a consensus. What's the best way to explain what's happening to you? That's what science means. It's not having a conformity of views. It's not having an approved biblical view. It's coming to a consensus about phenomena that are new, that are being revealed to us by these drugs, which once were new. And, we need to get back to doing proper science, which would also be proper medicine. And I dare I say it, proper religion, because religion is not, it becomes a case of just keeping the herd together. That's not what it's really supposed to be. Thank you.